Now let's talk about adrenoreceptor blockers. Alpha and beta adrenoreceptor blocking agents are divided into primary groups and subgroups on the basis of their receptor selectivity. All of these agents are pharmacological antagonists, or they are partial agonists. Most of them are reversible and competitive in action. Because alpha and beta blockers differ markedly in their effects and clinical applications, these drugs are considered separately in the following discussion. So they're divided into alpha blockers and beta blockers. Alpha blockers are selective or non-selective. For the selective ones, we have alpha 1 selective, and for the alpha 2 selective, we have yohimbine. Now let's talk about the non-selective ones. In the non-selective ones, we have reversible as well as irreversible. Now let's talk about the mnemonics and the examples. So for the alpha 1 selective, please remember P, and for the alpha 2 selective, please remember Y, and for the non-selective reversible, please remember P again, and for the non-selective reversible, please remember P again. So we have, for the alpha 1 selective, we have prazosin. For the alpha 2 selective, we have yohimbine, about the non-selective ones. So for that, we have reversible, for example, phentolamine. And for the reversible ones, please remember phenoxybenzamine. Okay, now let's talk about the beta blockers. So beta blockers can be beta 1 selective, beta 2 selective, or non-selective. So please remember MB for beta 1 selective and beta 2 selective. And you, of course, you know what the beta blocker non-selective example is. That is propranolol. Okay, so beta blocker, beta 1 selective example is metoprolol, and beta 2 selective example is butoxamine. Now let's talk about the further classification. So subdivisions are based on selective affinity as well as reversibility and duration of action. Now let's talk about the irreversible long-acting ones. So long-acting ones example is the one which is irreversible, which is phenoxybenzamine. Phenoxybenzamine is a prototypical long-acting alpha blocker, which differs from the adrenoreceptor blockers in being the only irreversible adrenoreceptor blocker in clinical use. It is slightly alpha 1 selective. And if we talk about the reversible, shorter acting ones, then the example is phentolamine. And prazosin is basically highly selective alpha 1 selective blocker. Doxazosine, trazosine, and tamsulosin are similar drugs like prazosin, which is alpha 1 blocker. The advantage of alpha 1 selectivity is discussed here. So alpha 2 selectivity, for example, yohimbine and ravolcine are alpha 1 selective competitive pharmacological antagonists. They are used primarily in research applications. Now let's talk about pharmacokinetics. All of them are active by the oral route as well as parenteral route. Though phentolamine is rarely given orally, it is mostly given through the parenteral route. Phenoxybenzamine has a shorter elimination half-life but a longer duration of action. Phenoxybenzamine duration of action is going to be 48 hours because it covalently binds to its receptor. Phentolamine has a duration of action, if it is given through the oral route, it is 2 to 4 hours, but if it is given parenterally, it is 20 to 40 minutes only. And now let's talk about prazosin. So 8 to 24 hours is this duration of action. Now let's talk about mechanism of action. Phenoxybenzamine will bind to the covalently to the alpha receptor. Thereby, it is going to produce irreversible blockade, which is insurmountable. Other alpha blocking agents are competitive antagonists, and their effects are surmountable by increasing the concentration of the agonists. So basically, because they are competitive blockers. This difference may be important in treatment of pheochromocytoma because the massive release of catecholamines from the tumor may overcome a reversible blockade. Now let's talk about competitive blockers. It is a surmountable antagonist that can be overcome by increasing the concentration of the agonist. For example, phentolamine, or the dose of the agonist. Now let's talk about the epinephrine reversal. Conversion of pressure response to epinephrine. So what is the pressure response to epinephrine? It is the increase in the blood pressure. So conversion of the pressure response to epinephrine, typical of large doses, to a blood pressure lowering effect caused by alpha blockers, which will unmask the beta 2 vasodilator effects of epinephrine. This is what we call the epinephrine reversal. Now let's talk about intrinsic sympathomimetic activity and membrane stabilizing activity. So intrinsic sympathomimetic activity is a partial agonist action which is produced by adrenoreceptor blockers, typical of several beta blockers, for example, pindolol as well as SC-butolol. Now let's talk about membrane stabilizing activity, which is a local anesthetic action, typical of several beta blockers, for example, propranolol is going to cause membrane stabilizing activity. So you can remember this with PM. What is an irreversible blocker? A non-surmountable inhibitor, usually because of covalent bond formation, for example, phenoxybenzamine. It is an example of irreversible blocker. Now let's talk about orthostatic hypotension, which is a hypotension that is not marked in the upright position. It is postural hypotension caused by Venous pooling of blood typical of alpha blockade or inadequate blood volume caused by blood volume or excess amount of diuresis or excessive diuresis. Now let's talk about partial agonist, which, for example, pindolol. It produces a smaller maximal effect than a full agonist, and it can act as inhibitor of agonist. Now, what is pheochromocytoma? It is basically a tumor of the adrenal gland, which will release varying amounts of norepinephrine and epinephrine into the circulation. Now let's talk about the effects which are produced by non-selective alpha blockers. So first of all, please remember that tachycardia is going to be exaggerated. These agents cause a predictable blockade of the alpha-mediated responses to sympathetic nervous system disorders and exogenous sympathomimetics. That is the alpha responses. The most important one is on the CVD, or cardiovascular system, a reduction in the vascular tone as well as a reduction in the pressure of both the arteries and the veins. There are no significant direct cardiac effects, so these effects are going to be indirect. However, the non-selective alpha blocker do cause baroreceptor-mediated reflex-mediated tachycardia as a result of drop in mean arterial pressure. Tachycardia is exaggerated because alpha-2 receptors on the adrenergic nerve terminals in the heart, which normally reduce the net release of norepinephrine, are blocked. Epinephrine reversal, it is basically the conversion of pressor response, which is mediated through the alpha receptors, to depressor response, which is mediated through the beta-2 receptors. So basically, the blood pressure increase is going to be converted to decrease in the blood pressure. Reversible of blood pressure, effect of large doses of epinephrine from a pressor response to a depressor response. It is called epinephrine reversal. The effect is not observed with phenylephrine or norepinephrine because these drugs do not have beta-2 effectors. So you're not going to observe epinephrine reversal in either phenylephrine or norepinephrine. Epinephrine reversal is manifested as orthostatic hypotension. It is seen as unexpected but predictable effect of drugs for which alpha blockade is an adverse effect. For example, it is seen in antihistamines as well as antipsychotic drugs, for example, phenothiazine antipsychotic agents. Now let's talk about selective alpha blockers. So they are going to cause tachycardia, but it is much less reflex tachycardia, and it is going to decrease the blood pressure because the prazosin and its analogs. So what was the example of selective blockers? Prazosin as well as all of its analogs. They are going to block the vascular alpha-1 receptors much more effectively than the alpha-2 receptors associated with the sympathetic system nerve endings. These drugs are going to reduce blood pressure with much less reflex tachycardia than the non-selective alpha blockers. They have useful relaxing effects on smooth muscles in the prostate gland. Now let's talk about the clinical uses of non-selective alpha blockers. So please remember PTC for that. So basically they are going to be used in pheochromocytoma. In the initial treatments of pheochromocytoma, we are going to give phenoxybenzamine, which is given in the preparatory phase. Then we are going to continue by giving phentolamine, which is sometimes given during surgery. So phenoxybenzamine also has serotonin receptor blocking effects, which justify its occasional use in carcinoid tumor. And it also has H1 antihistaminic effects, which lead to its use in mastocytosis because it has H1 antihistaminic effect. Okay, so this was for P, which was pheochromocytoma. Another thing that phentolamine does is that it reduces tissue damage, and accidental local infiltration of potent alpha agonists such as phenylephrine may lead to severe tissue ischemia and necrosis. And with phentolamine is sometimes used to prevent tissue damage. And also, if you do drug overdosage, for example, amphetamine or cocaine overdosage, then also you can use phentolamine. Sudden cessation of clonidine therapy is seen as rebound hypertension, and for that we can also use phentolamine. Okay, so now let's talk about Raynaud phenomena. It is going to sometimes respond to alpha blockers, but their efficacy is not well documented. Phentolamine or euhimbine is also used as by direct injection in the case of penile erection in men with erectile dysfunction. But oral phosphodiesterase inhibitors are more commonly used. Now let's talk about selective alpha blockers. So here we have prazosin, doxazosin, terazosin, tamsulosin. Okay, so but prazosin, doxazosin, and terazosin are used in hypertension. These alpha-1 blockers are used as well as tamsulosin and silodosin. They are also used to reduce urinary hesitancy, as well as they are going to prevent urinary retention in men with BPH. Talk about toxicity. So for toxicity, please remember VORT. So vasodilation, and then orthostatic hypotension, and then reflex tachycardia. These are the most important toxicities are simple extensions of alpha blocking effects. The main manifestation are orthostatic hypertension, which is which in the case of non-selective agents will cause reflex tachycardia. Tachycardia is less common and less severe with alpha 1 selective blockers. Phentolamine also has non-alpha mediated vasodilation effects. In patients with coronary disease, angina may be precipitated by tachycardia. Oral administration of some of these drugs will cause nausea and vomiting. The alpha 1 selective agents are associated with exaggerated tachycardia. Phentolamine is going to cause vasodilation. Alpha 1 selective agents are associated with exaggerated orthostatic hypotension in response to the first dose in some patients. Therefore, the first dose is really small and taken just before going to. Here we can see that when we give a large dose of epinephrine, it is basically blocked by large dose of alpha blockade. So there is a net difference effect. But when we give a large dose of phenylephrine, because it does not have any beta receptors, it is not actually blocked by alpha receptors, but there is suppression of the pressor effect. Now let's talk about beta blocking drugs. So classification, subgroups, and mechanisms. All of them are clinically important as competitive pharmacological antagonists. Propranolol is the prototype. Drugs in this group are classified into subgroups on the basis of beta 1 selectivity, partial agonist activity, local anesthetic activity, and lipid solubility. Metoprolol and betaxolol appear to have inverse agonist action. Now let's talk about receptor selectivity. Please remember the mnemonic of. For selectives, please remember AAME as in AME, and for non-selectives, please remember NPT. So, okay, beta 1 receptor selectivity in this beta 1 blockage is going to be more than beta 2 blockage. It is a property of AAME, which is acebutolol, atenolol, metoprolol, and esmolol, which is short-acting drug, and several other beta blockers. This is an advantage when treating patients with asthma because functioning of the beta 2 receptors are important in prevention of bronchospasm in such patients. Now let's talk about NPT, which are nadolol, propranolol, as well as timolol. They are typical non-selective beta blockers, betalol and carvedilol. They are going to be both alpha and beta blocking actions. Drugs are optimally active and different isomers have alpha and beta blocking action. Now let's talk about nebivolol. It has vasodilation action in addition to dose-dependent beta 1 selective antagonism. Now let's talk about partial agonist activity. It is manifested through the intrinsic sympathomimetic activity, which is basically shown by the acebutolol as well as pindolol. Partial agonist activity or intrinsic sympathomimetic activity. It has advantage in treating patients with asthma because in these drugs, at least in theory, they are less likely to cause bronchospasm. In contrast, propranolol, which is full antagonist, is more likely to cause severe bronchospasm in patients with airway disease. So never give propranolol to a patient with asthma. Now let's talk about local anesthetic activity. Which is a membrane stabilizing activity. It is mostly manifested by propranolol. It is a disadvantage when blockers are used topically in the eye because it decreases protective reflexes and increases the risk of ulceration or corneal ulceration. Local anesthetic effects are absent from timolol and several other beta blockers. That are useful in glaucoma. Now let's talk about pharmacokinetics. Most of the systemic agents have been developed for chronic or used, but bioavailability and action is going to vary widely. Esmolol is a short-acting beta ester, this is a beta blocker that is used only for entry. Nadolol is the longest-acting beta blocker. Acebutolol, atenolol, and nadolol are less lipid soluble, so they're less likely to enter into the CNS. Now let's talk about the effects and clinical uses first. Then we will talk about the classification. So first of all, what is it going to do clinically? So please remember the systems for that. First of all, we have the heart, then we have the lungs, and we have the eye. So what do you think when you think of the heart? Beta blockers are going to cause what? They're going to treat hypertension, angina, as well as arrhythmia. And so most of the organ level effects of beta blockers are predictable from blockage of beta receptor. Negative effects of sympathetic discharge, they are remarkably broad. Treatment of open angle glaucoma is common. It involves the use of several groups of autonomic drugs as well as other agents. CVD actions for beta blockers, especially in hypertension, angina, arrhythmias, are very important. Treatment of chronic but not acute heart failure is also very important. Application of beta blockers. Several large clinical trials have also been there, but not all beta blockers can reduce morbidity and mortality when properly used in chronic heart failure. A similar paradoxical benefit is also observed in COPD. Labetalol and carvedilol and metoprolol are used in CVD, or you can remember this in COPD. You can remember this with LCM. LCM is used in COPD. Pheochromocytoma can be treated with labetalol, especially if the tumor is producing large amounts of epinephrine and norepinephrine. CNS application is described later on. And also a novel and unexplainable benefit is the decrease in tremor as well as decrease in the size of the infantile hemangiomas because of propranolol. Now let's talk about toxicity. So when toxicity comes into your mind, please remember the mnemonic of HABIS. So HABIS. For that, what happens is that there's a risk of what? First of all, bradycardia, and then AV blockade, and then there's a risk of heart failure. Patients with asthmatic airway now. Okay, so they may suffer severe asthmatic effects. Attacks, although some patients with COPD can benefit from this. Beta blockers have also been used to reduce, they are going to reduce insulin secretion, but this does not appear to be clinically important. However, premonitory symptoms of hypoglycemia from insulin overdosage, tachycardia, anxiety, as well as tremor can be masked by beta blockers, and mobilization of glucose from the liver and sequestration of potassium with the skeletal muscles may be impaired. CNS adverse effects will include sedation, fatigue, sleep alteration, atenolol, nadolol, and others which do not enter the CNS. They are going to have less effects. Sexual dysfunction has been reported in some patients using beta blockers. Now let's talk about properties of several beta adrenoreceptor blocking drugs. So let's talk about each property. So which of these are non-selective? For that, please remember the mnemonic of Cl and PPT. So for C, we have carvedilol, and for L, we have labetalol. For N, we have nadolol. For P, we have propranolol, and for P, we have pindolol, and for T, we have timolol. All of them are non-selective. For the selective ones, we have all of the rest. So for remembering all of this is the mnemonic is AACE, LM, PPT. We can now let's talk about partial agonist activity. It is basically shown by PAL. So PAL, this is basically shown by P for pindolol, A for acetylol, and then L for labetalol. This is going to show the partial agonist activity. Now for the local anesthetic activity, please remember PPML as in Pakistan, which is a local party. Okay, so for that, propranolol, and then pindolol, and then metoprolol, and then labetalol. And now let's talk about liver solubility. So all of them are going to be low except for a few. Let's name those which have moderate liver solubility. For that, please remember CMPT, like carvedilol, metoprolol, pindolol, as well as timolol. They have moderate liver solubility, and propranolol has very high liver solubility. All of the rest have low liver solubility. Now let's talk about the most difficult thing, which is the half-life. So for the half-life, I have a very amazing mnemonics. So first of all, we have the song Apate. For that, I have APT. Okay. So first of all, let's start with A and P. What is A? A is acetylol, and then we have M, metoprolol, and then we have P, which is for pindolol. The half-life of this is 3 to 4 hours, and for propranolol, please remember that it has a half-life of 3.5 to 6 hours. And then for timolol, half-life is 4 to 5 hours. Then we have something with the mnemonic of LAC-NN. Okay, so LAC-NN. Labetalol. Okay, here you can see 5, 6, 7, and then we have directly 11 and 14. Labetalol has a half-life of 5 hours, atenolol 6 hours to 9 hours, carvedilol 7 hours to 10 hours, and then nevidolol 11 to 20 hours, and then nadolol, which has a half-life of 14 to 24 hours. And then we have esmolol has a short test half-life of 10 minutes, and it is only given through IV. Now let's talk about the last thing, which is basically drugs which are used in glaucoma. So for that, please remember CCOBAAP, COBAP, mnemonic for this. So first of all, we have cholinomimetics. They are given topically. And then we have carbonic anhydrases, which are given orally for acetazolamide, or they can be given topically for all others. For example, dorzolamide. And then we have something with an O, which is an osmotic agent, for example, mannitol. It is always given through IV. And then we have something which is going to be a beta blocker, for example, timolol. It is also given through topically. And then we have alpha agonist, which is non-selective. Example is epinephrine, and it is also given topically. Alpha 2 agonist example is apraclonidine, and it is also given topically. And then we have prostaglandin. It is also given topically. Example of prostaglandin is going to be ladonprost. Now let's talk about them in detail. Okay, so what are the examples of those which are going to decrease aqueous humor secretion? They are going to be CAB, CA2B, so beta blockers, and then we have carbonic anhydrase inhibitors as well as alpha 2 agonists. They are going to decrease the aqueous humor secretion. Okay, now let's talk about them in detail. Timolol is tropical, and it causes decreased secretion of aqueous humor from cellular epithelium. And then we have prostaglandins. Ladonprost is an example that causes increased outflow, and it is given through topically. Cholinomimetics are going to cause what? They're going to cause cerebral muscle contraction and then opening of the trabecular meshwork and then increasing the outflow. They can be given through topical drops or gel, plastic film, slow release inert. And then for alpha agonists, they are going to increase outflow through uveoscleral veins. Alpha 2 selective agonists, example are apraclonidine and bromronidine. They're going to decrease the aqueous secretion. Carbonic anhydrase inhibitors are going to decrease aqueous humor due to lack of bicarbonate. And then osmotic agents are going to remove water from the eye, and they are used for acute closed angle glaucoma.